That wasn't me. Sorry. Hold on just a second. Ms. Bernard? Mr. Cowan?
Here.
Mr. Furman?
Present in Detroit, Michigan.
Dr. Hans?
Here.
Mr. Landsman?
Here in Los Angeles County.
Mr. Lindemere?
Here.
Ms. Namie Dyer? Ms. Root?
Here.
Dr. Todd?
Here.
Mr. Torres?
He texted me he's going to be a little bit late.
And Dr. Guadalupe?
Here.
I'm sure I grabbed everybody. I think so. Yeah. Okay, we're good.
All right, thank you. Our next order of business is public comment.
At this time, we have no public comment signed in on the sheet or on the online form.
Thank you. All right, we will move on to Dana Lassenby, who is going to introduce our Chief Clinical Officer.
Good afternoon, everybody. It's really nice to see people in person. I'm excited to introduce our new Chief Clinical Officer, Ms. Kimberly Flowers. She comes to us with many, many years of experience, and she will take the lead over our access and crisis units, clinical services, and utilization management, as well as work extremely closely with Dr. Posios in making sure that our clinical pathways are well-defined and we're looking at those outcomes that we need for people we serve. So, Kim, do you want to say a few words about yourself, or hello to our board?
All right. Yes, thank you, Dana. I am happy to be part of the Oakland network. I've come to you directly from Wayne, Detroit Wayne Network for a while, and then, but much of my experience with CMH has been with the MCPNs as CareLink. I worked with CareLink for a number of years, and so I did a lot of work there, particularly with inpatient in hospitals. I am a nurse by my original degree is in nursing, so I did some nursing and managed care early on in my career, and then decided that I wanted to do some psychiatric work, and did that as well, to getting my degree at Oakland University, my LPC, and did some community work, and then again, more hospital director of nursing in inpatient settings. And then again, like I said, working with CareLink. So it's a pleasure to be here. I'm looking forward to understanding how Oakland County works. I'm in the works of that. I am 6 days new, so I have a lot to learn. And I find that when you're coming into a new system, many times you just need to be quiet and listen and learn and observe. Keep my comments to a minimum and write a lot of notes down. So my intention is to work very closely with Dr. Posios as he and I are still fairly new, but anxious to get busy and support the network and the persons that we serve. So thank you, Dana, for that introduction, and I look forward to maybe having some individual conversations as we move forward.
Hey,
Thank
Dana.
you. Oh, I'm sorry. Or Sarah, can I just do a reminder real quick?
Yes.
In order to not get feedback for the people who are at home, we need to make sure everybody's microphone is off unless you are actively speaking. It backfires on us if we don't do that. So thank you, everybody.
Thank you. And we just wanted to welcome you. We're excited to have you here and look forward to working with you. So welcome.
Thank you.
Yeah. All right, we will now move on to our business operations section of the meeting, and I will turn it over to Anya for our financial review.
Good afternoon, everybody. I have April financials for you. I think it must be Christine doing slides. You can move to the first slide. The first slide demonstrates our revenue for this fiscal year, so you can see October through April. The blue line going across is the prior fiscal year. So what you see is our revenue is consistently above last year's amounts, which is of course good news for us. In addition to that, you see April with a slight spike. That is the catch-up of the extension of the, I think it's $2.35 now, direct care wage that will now be monthly for the remainder of the fiscal year. Can move to the next slide, please. So this ties to that first slide in that we are paid on the number of eligibles every month, and so you can see each month we are over the number of eligibles that we had in the same month for the prior year. So that's definitely helping us on the revenue side and continues, that trend seems to be continuing, although starting to flatten just slightly. Right now, the Medicaid eligibility you cannot fall off of, so that's been one of the things that has been helpful throughout the pandemic, is that they're not doing redeterminations currently. I don't believe I've heard when that ends, although I would expect probably by the end of the fiscal year that will change. Next slide, please. So this chart looks at assets. So this is looking at assets compared to the end of fiscal year 20 versus April of this fiscal year. So you can see our cash and investments is up significantly. Receivables is down. Other assets is roughly flat. And then capital assets continues to go down with depreciation. Next slide. Liabilities down significantly from the end of the fiscal year, as you would expect. End of the fiscal year has a lot of accruals and whatnot going on in it. Due to state is roughly flat. Employee payables roughly flat, and then long-term debt continues to go down with our payments on long-term debt. Next slide, thank you. Net income is compared to last fiscal year, March of last fiscal year. So you can see our net income is, and total assets is up by about $2 million or a little more. Total liabilities is down, so that means our net position is up from $55 million to now $82 million. Next slide. So revenue comparison, this is again from March of last fiscal year to April of this fiscal year, so that's a year-over-year trend. Our Medicaid revenue is up significantly. General fund is just slightly below. County funds is exactly the same, and then all other is slightly lower because that includes things like grants. Thank you. Administration is down from last fiscal year. Provider network, you see that finally catching up. So that we've talked about several times in a row over the last few months, that we were waiting for those direct care wage and payments to go out. So that's really was what the holdup was. So that's definitely creeping back up there, which is good. Grants is up slightly down slightly from last fiscal year. Looking at my own screen, it's hard to see. And then all other is roughly flat. So the net position compared to September of fiscal year 20, total revenue is up. Total expenses is just about flat, within a couple $1 million. And so our net income is up by about almost $27 million. So this is just a list of our top 15 providers that were paid this month. And then the next few slides should be just the description of those providers. And with that, I will take any questions.
Hi. I wondered if you could talk about the increase on the direct care wage going from $2 an hour to $2.35 an hour, and where did the additional revenue come from?
So that was a decision the legislature made when they extended it past, I'm trying to remember now, I think it was the end of February through the remainder of the fiscal year. So they did that. I believe it was CARES money that they utilized to fund that. Fingers crossed, we're going to see that continue into next fiscal year. I do know that it has been mentioned in the budget, if nothing else other than a placeholder in one of them, but we're hopeful that they'll continue it.
Any questions from anyone attending remotely? All right, not seeing any. Okay. All right. Our next item is our contractual obligations, and this is going to be turning over to Diana.
Good afternoon, everyone. I am asking for approval to enter into a 3-year agreement with Illuminate, who is a IT security company, in an amount of not to exceed $134,550. It is best practice to have security audits by a third party to identify really our risk areas as well as areas where we may not be where we want to, or that they're helping us identify risks that we weren't aware of, just like the same that we have third-party financial audits. We issued an RFP earlier in the year, and we received 9 responses, and 4 vendors were invited back for verbal presentations. Illuminate was recommended by the review committee for the following reasons: their experience in security audits, their understanding of OCHN's needs, and clear timelines. What we did going into this contract, and you'll notice that the numbers vary. The first year is higher than years 2 and 3. And the reason for that is we said, and we looked at and identified what was really key to helping keep our infrastructure secure and that we could also manage. So the first year is not only a routine security audit, but it also includes looking at our policies and procedures and some interviews and other things that are a little bit more in depth. Our policies and procedures tend to, in requirements by HIPAA, there's very few changes. So we looked and we said, you know what, we're not going to do that every year because it gets hard to respond to those. So in our first year, we have a full audit that is $69,000. And then in year 2 and year 3, we go down to penetration testing, which is a way that they try to access our systems from the outside and see if they can access them. Social engineering, that is still one of our biggest risks of an organization. It's the users, whether intentional or not. And things start to get even, the hackers are getting better and better. A firewall review, which is what protects our network and helps, once again, helps keep people out. So we want that to be reviewed to make sure that there aren't any risk there. And then for 365, 365 really holds a majority of our data outside of our electronic healthcare record, and it's always changing. So it's really easy to maybe not catch something that should be configured or made a certain way. So we want them to look at our risk and be able to help us identify any holes in it. As part of this contract, they will come back and help us with mitigation measures, as well as helping us with corrective action plans. I did add a 15% contingency, so the actual contract is $117,000, and then I added a 15% contingency in case we needed any other services for them, in the amount of $17,550 for a total contract amount of just over $134,000. Are there any questions?
Can you talk a little bit about the kinds of data that we need to protect as an organization and why it's so important to do this?
Yeah, that's a really great question, Eric. So, we have protected health information. So when we look at everybody's healthcare data that may be not only sitting in our electronic healthcare record, but they may be sitting in reports and other aspects, we want to make sure that that is protected, as well as personally identifiable information as well. So things like employees, dates of birth, social security numbers. So that's all really important data that we either have, obligations to protect, or you just really need to protect it due to industry standards.
Thank you. I know how important it is for people to have confidence that their data is safe with our network. Thank you.
Absolutely. And that's something that we always want to make sure is that everybody feels that we're doing the best job that we can to keep their information safe.
I know that there is always I shouldn't say always, several times we've had the conversation of who is on the team. So could you just share how many staff or what was the makeup
on the review committee?
On the review committee.
I'm going to ask Peter that question because I was actually not on the review committee.
Okay. And I don't mean to put you on the spot, but
that's okay, no worries. But he's prepared. He came prepared today.
So the recommendation committee consisted of Andrew Naumo, and so he's my systems administrator. We had Brittany Campbell from Administrative and Special Projects Coordinator out of the Fiscal Department, which now is under Kalana for Contracts and Legal. We had Chris McFatridge, the Systems Administrator. We had Jen Hillier from the Procurement Specialist. We had Marquita Massey, because she's the Corporate Compliance Officer, so we wanted her to be included on that as well, and myself.
Great, thank you so much. I just want to make sure I'm not missing any questions remotely.
I have a question. It's Hedis. I had trouble getting on my Teams. That's why I'm not on it. Okay, so 2 questions. The first is, and also thank you for your presentation, the costs are obviously over a 3-year period. Do you know what the costs were over the past 3 years? Just like, I was curious with inflation and changes, what the difference is.
I followed my own direction and turned off my microphone, and then I forgot to turn it back on. We have not utilized these services in the last 3 years, but the last audit that we had done was about $65,000, so that year 1 cost is very much in line with that.
Okay, I understand. So when was the last time we did do this? What year was it?
2016. So when I came in, we completely redid our infrastructure, and then we moved to 365, and then we had COVID. So we really want to make sure that we're getting this done and that this is going to get us now on a track that we will be maintaining every year.
Yeah, no, that makes great sense.
It's a great question. Thanks, Hedis.
Sure. I actually have 2 other questions. So the second one is, I understand that you created the 15% in case there's more that we need to spend on their end in case it doesn't end up costing them as much as they thought it would. Is there any reduction of costs in the contract, or is that just like completely unheard of that wouldn't happen?
So that they cannot spend that money without our approval. So that would be if we decided to add an extra service. So let's say the audit comes back and we say that we need their help or recommendation formulating a mitigation strategy, we could pay them to do that. Or
Right,
if we
I
ran into
understood
some
that.
kind of security issue. So they cannot access that money without our approval.
I
So they
understood
cannot
that.
go
The
over.
Sure. The question actually was, which might be unrealistic, is that if somehow it costs less for them to do the job, will they reduce the pricing?
This is, I believe, a not to exceed contract. Is that right, Kalana?
That is correct. So, but I think what she's asking is whether or not if they bill for services, if their services happen to fall below, will they be entitled to the full amount? And right now, it is expected that all of the services that are outlined in the actual proposal are the services that we've determined that are needed, and so it is expected that those services will be performed. In the event that there is a deviation from the actual services, we will come back to the table to discuss it, but I don't anticipate that being the case given the amount of time that has lapsed since the previous audit.
Okay, great. And then this isn't really a question for the 2 of you, it's more of a question for Dana and really the board, just something to put on the back burner of discussion, but it is committee of the whole, so we can bring these things up. And that is, at what point and where do we determine when you guys are hiring different organizations, like when a board member might be on a, on the committee? Like we just got the list of the 7 people, I think, who are on this committee to review the contracts. I know the board has asked in the past the possibility of being on some of those committees. So I just think we need to kind of discuss at some point, or maybe I'll ask John, what type of contracts should perhaps a board member be on, if possible, to be on the review committee. Just to put that out there for another time.
We'll definitely follow up with more detail, but traditionally, board members are not a part of the RFP committees because those are internal committee meetings reviewing contracts. So we try to, and I see an opportunity for us to do a better job of putting them out there when we are posting the RFPs or RFIs or RFQs, so that this board is aware of when we're doing that and the timelines that we're going to follow to review and then select a vendor. But traditionally, and I think there's something in the bylaws or some place, and I'll have to check, that board members don't typically sit on RFU and review those proposals.
Okay, for some reason, there were a couple board members on a few RFPs in the last 3 years, so that's why I thought that sometimes that there was I guess maybe it depends on if a board member is a specialist or something. Okay, thank you, those were all my questions.
I think board members were on the one for the search committee, for the CEO search committee.
So it was the search committee and the investment firm, and that's because the investment firm is directly related to the investments the organization invests in, and so therefore they sit on that committee.
Thank you. Dr. Tom?
I've sat on an RFP committee that was picking the auditing company. Jonathan's been on an RFP. I think, Malkiah, you have. So when it's something pertinent to board members, they always ask if any board members want to volunteer. And I think it would be interesting if you do it at least one. I wouldn't do it again. But no, it's really thorough and a lot of work. And I have a lot of faith in the people that want to put in that much work on making a decision. But there are certain things that the board would be interested in, like the auditors. For instance, I was on that one.
Yeah.
And so that one is specifically because the auditors report directly to you as the board, same with the investment company. So anytime it's a report directly to the board, we typically will invite board members to sit on it.
Yeah, so maybe we could have a list such as the investment committee, the audit, because obviously you're going to change investment for sometimes. You're going to need to review the audit sometimes. And then I know for the real estate hiring brokerage, I sat on that committee. And then I think you mentioned that there was one more. So maybe just for the ones like that, maybe get it a little spelled out, just for the new members to understand that sometimes we are in RFPs and sometimes we're not.
Thank you. Jonathan?
Thank you. I was going to add to that same line of comments that, yes, where we had expertise, it made sense. And if we had the time to do it as well, whether it was tied to the board or not. I have a question specifically related to this contract. I know you had mentioned penetration testing, and it may help the board to understand what that means. But the second one is because there's been a lot of cyber crime in the past maybe 3-4 weeks where pipelines have been shut down, hospitals and health systems and others have been held at ransom. Will this help us find those hits? Does this include that kind of coverage? Do we have coverage to pay ransomware? So that would be a second question, if you will. Diane.
So I will turn over the policy to Kalana, but as far as helping us identify what our risk is, and once again, with that penetration testing, and all of those components, it really is to help do whatever we can that's in our power to be able to prevent those. And, Jonathan, I know that this is an area and, that you are familiar with. And, as you know, it's always a game of kind of trying to figure out if you can outrun the bad people, and you just hope that you are running faster than them.
Right. Well, a few years ago, Macomb County had an issue where they got hacked into. They were at ransom. They had some coverages. I don't know how they executed on it, but they did finally get their systems back. And that brought their organization, they said not to a standstill, but it did slow them down dramatically. And they are not as big as we are.
This is Kalana. We do have actual cybersecurity coverage under our MMRMA policy. As it relates to any ransom, it would have to be something that's a credible threat and not qualify for an exclusionary reason under our policy. So it would be dependent upon the circumstances at hand at the time.
Okay, thank you. And the last thing I wanted to point out is, while you said this contract is a not to exceed, it sounds more like it's a fixed price. That's the flat fee we're going to pay unless we want to engage them for additional work.
That is correct. As I was sitting here afterwards, I'm like, this is not a time and materials, that this is a fixed cost. And then anything that we would ask for them to do afterwards would be time and material.
That's all I have. I'm going to lower my hand.
All right. Thank you, Diana. So you'll be taking this to a vote at the board meeting.
is correct. Thank
All
you.
right, thank you. All right, with that, we are going to move on to our policy management component of tonight's meeting with our quarterly updates, and we will start with our SUD team with Christina Nicholas. Or Nick, did I say that right? Nicholas, yeah, sorry.
You said it exactly right. Thank you so much. Good evening, everyone. Happy to be here and to give my quarterly report. If you could advance the slide, please. This is me, of course. You can advance that as well. So just a quick recap. Right now, you heard earlier that Access is transitioning away from my purview, but right now I oversee Access, Justice, and Substance Use Disorder Services, soon to be Justice and Substance Use. Next slide, please. So the three initiatives I'm going to speak about tonight with Access is I'm going to give a brief overview of our mental health and substance use disorder screening integration. For Justice, I'm going to talk about our long excited to fully discuss co-responder model. And in substance use, our prevention needs assessment. Next slide, please. So for Access integration, this is an annual plan goal, and really it is to make services easier, more timely for individuals who have both a mental health and a substance use disorder. To give people some history to this, when we were a coordinating agency before substance use services merged with mental health, we had a separate Access center. And then when the first year we merged, we kept the Access Center with the county so we could fully prepare the community for the changes. After a year, we brought in Access, and then we truly started looking at what was needed to be done in order to integrate. And so it is a phased implementation approach. It's really important that when a person calls, if they need to be screened for more than one service, that it's done at the time of the screening, and not having to switch or come to different appointment times to be screened for substance use or mental health. Again, our whole importance of outcomes is our commitment to best practices, quality measures, and most important, ensuring that a person served is receiving the highest standard of care. And truly to integrate screening is the way to do that. And we are on track to be fully completed by the end of this fiscal year, which is very exciting. So we've engaged in a great deal of cross-training because staff members were hired before we were integrated. So there were staff members that had specific expertise in substance use and staff members that had specific expertise in mental health. And so we've done a great deal of cross-training, job shadowing, and the Access screeners are doing a phenomenal job in doing this. And I'm happy to say that we're pretty much there. Next slide, please. So if you see, I just thought this was important to share, people that are seeking substance use and are open with a core provider, just to see that, because that's generally where you see the difference, is that it's generally someone that is already open with a core provider. This is what the data is telling us, and tends to be seeking services for substance use disorders, largely are higher levels of care. And so individuals with co-occurring disorders that really need a higher level of care in substance use, and then will transition back to their mental health provider to receive co-occurring services for aftercare. And you can see largely here, Easter Seals has the largest amount, followed by CNS and then TTI. And we don't have a high prevalence of individuals with substance use disorders having very serious mental illness. It's just what the data is showing us. However, it does happen, and we need to be prepared to be able to screen people for any type of service they need. And I'm, again, happy to say we're doing that. Next slide, please. And with that, any questions on the Access annual plan goal? Okay, next slide, please. This is so very exciting and has been worked on for a long time, including policies and protocols and procedures. And that is to increase our collaboration with law enforcement partners. And we were very fortunate, and I know Dana has mentioned this before, that 3 local police agencies came together and wanted to embed a clinician that is a staff person of Oakland Community Health Network and provide co-response and follow-up for citizens experiencing mental health, substance use, or any behavioral health crisis. That is so exciting. It's really, really moving to the next level and something that I truly believe will be an excellent resource for our community and especially these 3 communities. So the communities are Auburn Hills, Birmingham, and Bloomfield Township. They all approved an interlocal. We attended the council meetings in case there was any questions that needed to be asked, and unanimously each city approved to fund this position. We say the position is currently posted, and that was at the time of writing this and when I needed to submit it. Candidates were being reviewed, but we already started our first interview today. So we're really excited for that. And, you know, the hope to improve connections to supports and services, to really, really foster more positive interactions with police officers, and also to improve systems navigation. Sometimes, especially when people are in crisis, they just don't know what to do. And to have someone on the spot to help navigate, that could even do a screening if needed, is just an amazing project. And we are so very excited about it. And really all the prep work is complete. Our staff members, Siri and Kathy and Dan, worked so hard with the police departments to write excellent, thorough protocols, and we're ready to go. We're really there with implementation. So I'm very excited about that. Next slide. Any questions?
You've got several, so I will start with Melchiah.
Okay.
Thank you. That's exciting news. But looking at the communities that are involved, can we go back to the previous slide, please? Bloomfield, Auburn Hills, and Birmingham. With one person, how are they going to collaborate with those 3 different departments?
So that's an excellent question, Melchiah. They worked very closely together. They're looking very closely at data and seeing what are the peak times, what are the peak times in each city. They're going to start with the clinician being at one department each day, and then based on needs and follow-up, split the last 2 days of the week, so it's a full-time position. They also know that things may be quiet in one city, where they, even if it's their day, they're assigned to that they move to the next city if there's something there. The collaboration between these 3 departments has just been exceptional, and they understand that. I suspect if this takes off the way that we suspect it will, that they may expand. But the data needs to be gathered for that, and they really needed to pool resources. So we have some specific days that may be flexible, and this next year will be the true time to determine exactly what we need to do and what tweaks we need to make.
Thank you, Christina. With one quick follow-up.
Sure.
What if the clinician is in one department and something breaks out in the other department? I mean, one person can only be in one place at one time.
You are absolutely correct. And, you know, taking care of the clinician's mental health is extremely important as well. And we've talked about that. And if they know that this person cannot be in more than one place at a time. And so that's where the follow-up is very, very key. And so, and they put a heavy emphasis on follow-up. And so the clinician may be responding to something else and something happens. And then there's a mechanism for, you know, for lack of a better word, for a referral to take place. And then the clinician will be doing follow-up with individuals and families and whoever needs it. So you're right. They may not be able to respond immediately, but they will certainly be following up as well to help individuals navigate whatever they need.
Thank you.
You're welcome.
Eric?
Hi, I was just curious as to the three communities that were chosen, if that's the right word. Why three and why those three? And then could you talk a little bit about the process of what it was like to talk to communities about this kind of a program?
Sure, sure. Well, they weren't chosen. They approached us. So they came together. And really, there's Deputy Chief Gagnon from Auburn Hills. Worked very diligently on this. He started doing a lot of research on it because he knew. The other thing is we see this commitment from these three departments that they want to better address a person's behavioral health needs. This is also about receiving additional training, but having someone there with the skills and the knowledge and the licensure to be able to address things that officers may not be able to. And so to answer that question, they came together, they worked with their departments, and they approached us. So we didn't pick. And they're fully funding it, which is very exciting. So I wonder if I didn't answer your second question. I apologize. What was your second question?
I think you've answered my general questions, and you also snuck in an answer to a follow-up question. I was going to ask about the funding of the program. So I'm glad you covered that. Thanks.
Yeah, you're welcome. Yes, they applied for grants, but they also received full approval from all three cities that they will fund it if the grants do not come to fruition.
Oh, go ahead. John Paul.
Thank you. I had a question with regard to the funding, so it sounds like it's clarified. But is it for a fiscal year then within those communities? Is it just for 1 year right now?
Their intent is to continue this unless the data shows that it's not needed. But they are very committed to this, and they hope to see it long term.
Okay. And then, so this employee will be a OCHN employee, correct?
Yes.
Okay, so we're the fiduciary, then they're giving us the money, and then we're okay. And then the qualifications, they're a clinician. Are they? I didn't see the job posting, so would it be in there that they have some background in criminal justice or things like that?
Yes, heavy emphasis is placed on that, both in understanding our system and being able to navigate it, but also in having experience working with law enforcement in various capacities. It is definitely extremely important.
Okay. Yeah, I think that's important because sometimes you might walk into a traumatic situation like police officers do, and especially because if I understand it correctly, they're going out in a crisis situation to help, whether it's help the police navigate that situation that they're in or after the fact to navigate that person in the right direction to get the services.
Correct.
Correct, okay. And then it's Bloomfield, Auburn Hills, and then,
Birmingham.
And Birmingham. So those are all, within range of each other as far as geographically it goes. And I've seen some similar things like this with school districts as well, collaborating that are neighboring with each other, and it seems to work out really good. And it's a good way for, for them to provide this opportunity or this service to the community with, just funding one person. And I guess if it's just one now, but the good thing is at least it's one. And then potentially if it is something that works, it can grow even further. So it sounds like a great collaboration, so it's nice to see.
We're very excited. You're welcome.
Dana?
I just wanted to add, we were approached by the Board of Commissioners with an interest in expanding this program. So we've provided some information to the Board of Commissioners, and we're actually going to give them an update, I believe, on Thursday to talk more about how we can expand this to other communities within Oakland County.
Thank you. Christina?
Thank you, Christina. This is really exciting.
So it sounds like there's a plan in place to evaluate the success of the program and then areas for improvement. I'm just wondering, as part of that plan, will feedback be collected from community members who have contact with this OCHN employee?
Certainly, it's always the intent to seek community feedback. The most important feedback is by the people we serve, certainly. And so there are numerous data collection points that we're discussing currently, and that will be in place when the position starts, as well as surveying the effectiveness of the program.
Okay, that's great. Thank you. I have one more question. As board members, are we able to have access to some of the protocols that were created, just in case any of us want to like read more about how the program is set up?
I don't see why that would be an issue.
Okay. Thank you.
Anyone attending remotely that has any questions? Oh, Dr. Hahn, sorry.
I'm just curious as to what does the data show? What locality is this need most important? And if that would be a consideration in expanding this program? And also my follow-up would be, how can we generate funding resources for that?
So those are some very good questions. There are a lot of grants that are out and will continue to be published. This is a very important topic right now, and one that's probably been needed for a very long time. And then in terms of the locality, really what they've studied more is when they have issues, when those peak hours are. All three communities have determined that they have a heavy need for it. And I would argue, without looking at data from other communities, that every community, as this is a public benefit, really has people that experience crises and has officers that would be very happy to have someone with the expertise to help address those. But the data, you're right, is unique to each community. And all three were able to demonstrate that they have peak hours of time where they have, for example, calls from individuals that they have on a regular basis, or in general, people with substance use disorders that are in need of assistance, or just family members that are having issues, domestic violence situations. I wish I could say there was not the data showing the need, but it is certainly there.
All right. Eric's got another question for you.
Can you talk a little bit when you were answering the previous questions? What came to mind is our definition of law enforcement. So in the phone calls that come in, often it's the 911 operator staff that understand, those people in the community that are constantly calling and calling and calling, and probably have a quicker ability to recognize when people are in crisis, because often they'll tend to get and to know the community, especially if they are haven't been privatized out and that they actually work for the local community. So I wondered if you could talk about how that fits into the plan.
That is an excellent question as well. So this individual is going to be furnished with a radio. They're going to have a vehicle, and so they will have a mechanism and a phone. And so they'll have a mechanism for dispatch to call right away. And so this collaborative is extremely important for everyone to work together. And that's part of the protocols, is involving the entire department and understanding the importance of this and how to gain access and utilize the services of the clinician.
Thank you.
If
Right,
there
I
are
think
no,
we're good to move on. Thank you.
okay. Okay, so for substance use, I wanted to give an update on our needs assessment. It is in our annual plan goal that we conduct a prevention needs assessment. The prevention needs assessment is required by the Michigan Department of Health and Human Services to determine priority issues to be addressed for prevention. There is also the required model, which is the strategic prevention framework that came from SAMHSA. And we have a consultant that is helping us through this process and facilitating the needs assessment. The needs assessment's comprised of several different community members from numerous sectors, and it involves going over a huge amount of data pertaining to Oakland County. So priority issues based on that data can be determined for the next 3 to 5 years. And what happens with that is that once the priority issues are determined, then it tailors our RFP for prevention services. And those are the issues that we ask people to respond to and the services we expect them to provide. So that's currently in progress. It's very exciting. We have individuals from the business sector, from provider agencies, from youth assistance, from law enforcement, to name a few, that are all involved and willing to participate in what is a 2-month process of 2 hours a week in working together to determine what those needs are for Oakland County. And we will conclude that at the end of this month. And then the issues will be determined, and then we will prepare for the RFP. So to talk funding sources, I do lump all of the services that I oversee together. So access, as I've talked about before, is really comprised of all of our funding sources, largely Medicaid, Healthy Michigan, and the Substance Use Block Grant. This justice service in particular is with grants and, as I mentioned, the participating cities. And substance use disorders, it is being funded through our block grant and or our Public Act 2 funds for the needs assessment. Any questions?
Elkaya?
I don't know if anyone can hear me, but I am not able to hear anything.
Just so you know, Christina,
I
it's,
can't hear her either.
yeah, I can't hear either.
Okay, you're probably on mute.
Oh, okay.
Thank you. I'm not on mute. Christina, when it comes to prevention services, aren't the services that we provide strictly targeted towards youth?
You know, a lot of times the needs assessment drives that. So, for example, some of the services we provide now address adult binge drinking. But you are correct that the majority of prevention services tend to be tailored towards youth because we're looking to prevent the onset of a substance use disorder, where those that already have that are receiving treatment services. And so it is important to provide services for kids early on to avoid that onset.
So I'm just sorry, one other follow-up. So if we're providing some prevention services to adults, what type of organization would we be looking for to provide the prevention services? Because right now, isn't it the, I can't think of the name, that's here in the building, that's providing our coalition, community coalition?
Yep.
They're the ones that are providing prevention services now. So would it be someone else? Because don't they mainly provide to youth?
So the Alliance of Coalitions for Healthy Communities that you're speaking of is one of our prevention providers. And yes, their prevention coalitions do address primarily youth services. Their school-based programs provide predominantly youth services, but they also have prevention and recovery support that addresses individuals and support for people who may have family members that use substances, and also for people who are in recovery and want to prevent a reoccurrence of use. But they are only one of our prevention providers. We have numerous others. And quite honestly, what will happen is the RFP will determine who our next set of providers are.
Eric?
I'm not sure that this, the comment that I'm going to raise is, it may fit in here, it may not. But something recently had resurfaced in my mind, and I had actually talked to John Paul about it. And, you know, so one of the problems when, with substance use and working with the courts is that people often come in contact with the court system through involuntary measures, and they are encouraged to attend AA meetings. And what generally happens is the probation officer will give somebody a sheet of paper, and they will say, okay, you've got to attend, you know, I don't know, the common thing is 90 meetings in 90 days in AA, right? And so that, you know, there's a column there for, you know, the meeting that they went to and, you know, who the leader was, and then the date that they attended the meeting. It's clear to me that in our justice system that probation officers and others that are involved in substance use do not understand the AA program. And so I'm fearful that they are just really churning people through a system. And I think it would be very helpful to the system and to actually people that are that have a chance at recovery if they were actually told that they should, you know, there are several different types of meetings within AA, right? There's going to be, you know, a general meeting like we're all sitting around and we're going to talk about what we do for our own recovery. There's going to be meetings where you go and you talk about how you work through, you know, one of the 12 steps. And so you know, they're called step meetings. And so they'll go into detail about how you work the first step, how you work the second step, et cetera. There are meetings then also about, that are called big book studies. And so then you are, and the big book study is the book, is the pathway, and it's the core of what the program is. And I could have broke down in tears recently when somebody was talking about their road to recovery, and they said that AA didn't work. And during their story, they said, you know, there's not a book for recovery. And I could have broken down in tears because there is a book. It's called The Big Book, and people that follow that path, they are successful in the program. And it's up to us in the AA community to carry that message to other people. And this person that didn't know that there was a book, that's my fault. That's people that are in these that go to meetings. It's our responsibility to make sure that people are coming in and seeking recovery understand these things. And so if there's if there's any way for us to work with in the court system or the law enforcement system to help them understand so that when people are coming in to talk to their probation officer and that they learn and they're required to go to AA, that they just don't give the probation officer a couple of buzzwords and they're on their way, that the probation officer could truly understand whether or not the person is attending and paying attention in those meetings. Because for me, that path to recovery changed my life. And so it's just food for thought. If we ever have a chance to do that, I think that we could help a greater percentage of people that are seeking recovery or have that opportunity to seek recovery be more successful. Thank you.
Sure, makes sense. You're correct. This may not have anything specifically to do with our prevention services, but being in the field 25 years, I very much understand what you are saying in terms of a person's path to recovery, whether it be through AA or NA in the various programs, or if it's through Smart Recovery or Celebrate Recovery, but that there is more to it than just signing sheets. And I think maybe this is something that we could continue this conversation, perhaps even at the Oversight Policy Board meeting, in terms of helping the justice system, and in particular parole and probation officers, really what recovery support groups are about. So thank you so much for your thoughts. I appreciate it.
Thanks.
Any other questions? Okay, again, thank you so much for allowing me to present tonight. I look forward to our next quarterly update, and have a good night, everybody.
Thank you, Christina. We appreciate your time and efforts and great presentation. Thanks.
Thank you.
And we will hand it over now to the clinical team quarterly update with Stephanie Wilson.
Good evening, everyone. So I'm going to be presenting on the Q2 quarterly clinical team update. And you can go to the next slide. Thank you. So just for a brief review, for the clinical practice team department overview, the areas that we work on are really ensuring the use of evidence-based and best practices, person-centered planning, as well as utilization management and review of all services. So within the clinical practice team sits the utilization management and review team, and that team's made up of 17 staff, and then the clinical and integrated health team, which has 16 staff. And some of the initiatives and responsibilities related to the clinical practice team's work include integrated care, clinical review, audit reporting, and utilization management and review. Next slide. So for Q2, I'm going to provide quarterly initiative updates related to our behavioral health homes, integrated healthcare, and suicide prevention efforts. So I'm going to start off with the Behavioral Health Homes Initiative to give some updates related to Q2. So just to refresh from my Q1 updates, this is related to the Health and Wellness Annual Plan Goal, and this is targeting the implementation of behavioral health homes within our provider network and with community partners. So we're currently working in FY21 on expanding the current care coordination efforts, and this will allow for more individuals across Oakland County to be able to receive that care coordination through behavioral health homes. So we've partnered with our provider network within OCHN along with Honor Health to offer enhanced care coordination. And so in Q2, we increased the number of our OCHN providers who were enrolling individuals with behavioral health homes. So in Q1, we had 3 providers that were enrolling. In Q2, we have 5 providers that are enrolling in behavioral health home services. And so there is a bar graph over there on the right-hand side that just is a breakdown for Q2 by provider and this is related to behavioral health home enrollment requests. So as you can see there, the lighter purple, or the majority of that bar, includes those that were eligible, along with anyone who wasn't eligible, any pending requests, or someone who may have declined the service. So we are offering this for individuals who meet eligibility. And again, the behavioral health home eligibility is different than the specialty mental health services through OCHN. So if an individual has Medicaid as their primary insurance coverage, as well as a qualifying diagnosis, and I went over some of those last time, but those include diagnoses such as anxiety, depression, bipolar disorder. If they have one of those along with Medicaid, they would qualify for services through behavioral health home programs. This in Q2, we recently began enrolling youth. So that's an exciting new part that has been an update in Q2. So we do have youth who are now enrolling in behavioral health homes. We also have individuals who are not necessarily open through specialty mental health care services with OCHN. So we originally had targeted that group just because that seemed like a way to start getting people and our providers used to how that process works, but we've since opened that up so providers can enroll individuals in behavioral health homes that aren't necessarily open with services through OCHN's network. And Honor Health has also just a couple of weeks ago, so just outside of Q2, but they have also begun enrolling individuals now. So we're really excited for that. I do have the number of 393 enrollees was as of 6/2, but I did check our Power BI dashboard this morning. So as of this morning, we had 416 individuals currently enrolled with behavioral health homes. And I will say we have regular meetings with the state of Michigan. In the meeting that was attended last week, a little over 75% of behavioral health home enrollees across the state are in Oakland County. So that tells us that we're doing a really great job across our network and as well as Honor Health with identifying individuals who could benefit from this and also getting those individuals enrolled. So we're excited about that, and I think we're going to see this number continue to grow as we have more and more providers enrolling, and now with Honor Health. Next slide, please. So for funding source, we do receive funding from the state of Michigan, including state and federal Medicaid dollars, and the behavioral health homes was budgeted for FY21. So any questions related to Q2 updates for behavioral health homes?
Not seeing any.
All right. So I'll move on to the second initiative, which is integrated healthcare. And so this relates to the technology and innovation as well as health and wellness annual plan goals. And so we're looking at our continued implementation of complex case management, care coordination, along with the use of Hedis measures and how we're looking at measuring our progress along the way. So this involves our OCHN's nurse case managers. They're working with assisting individuals with physical and behavioral health conditions that could place them at high risk. I would also like to know in Q2, we were able to add a full-time peer navigator to our integrated healthcare team. That is one of the positions that is funded through the Adult Mental Health Block Grant related to integrated healthcare. And so she has been a really valued member and added a lot to our integrated healthcare team. So we are happy to have her on board now as of Q2. So one of the measures that I reported on last time that I wanted to bring an update from Q2 was Hedis Measure 304. And we do look at various Hedis measures utilizing our population health management tool, but Hedis Measure 304 is something that we report on related to our NCQA accreditation as well as HSAG review. So this one we is highlighted for this year to really work towards our goal and monitor how we're doing. This Hedis measure is specific to the percentage of patients who are from the age of 18 to 64 with schizophrenia or bipolar disorder who received an antipsychotic medication and also had a diabetes screening during that measurement year, which would be this fiscal year. So our goal for this fiscal year is 80%. Currently, you can see in Q1 we were at 75, Q2 we're at 74. So we're getting closer. I will say in fiscal year 20, our goal was 80%, and our overall year total was 70%. So we are seeing some improvement. We're going to keep working to improve that, working with our nurse case managers. Our peer navigator has recently been assisting with some of the outreach we're doing as far as sending letters, completing phone calls to individuals to help promote diabetes screening, to offer any support or assistance if we can assist with that, and linking with our provider network and being able to do that. So that is the one area, and like I said, we will continue to bring updated information on where we're at as we work towards that goal of 80% for this year. As well as through integrated health, continuing to provide that complex case management program through our nurse case managers, care coordination with the Medicaid health plans in Oakland County, and the ongoing review of those measures, particularly working towards our goal for Measure 304. And with this goal, where we're looking at overall improvement of health of individuals receiving services through OCHN and helping to improve a person's service experience as well. So we continue to be in progress towards this goal. It does receive funding through Medicaid, administrative funds, and also through grant funding through the integrated care efforts, and this is included in our FY21 budget. Questions related?
I had a question for you.
Sure.
Okay.
Hi, Stephanie. Can we go back to the slide that had the one before that? Yes, the Hedis measure. I'm just curious. You might have shared this the last time we went through this, but does having schizophrenia or bipolar and being dispensed at an antipsychotic cause people to have diabetes? Is that why they're looking for this, and it's set so high?
Sure. So that's a good question. It's not necessarily that it's a cause. I think it has been identified as some risk factors associated with the diagnosis of that and having an antipsychotic, and also just looking at diabetes and the presence of that in that population. So while it's not necessarily like a direct causal relationship, I think there have been some identified risk factors that prompted the Hedis measure being how it is.
So just a quick follow-up. Even if they aren't prescribed the antipsychotic, there's a possibility they could develop diabetes. So anybody that has schizophrenia or bipolar should be tested?
I mean, certainly, I think depending on the recommendations from their primary care, whatever physical health care provider, they may recommend a diabetes screening based on blood work or different things. So I would never discourage someone, but this one is specific to if both are present for the diagnoses and the use of the antipsychotic.
Thank you.
Dr. Hans?
Yes, to follow up Malkaya's point, I think it's very important. Several antipsychotic drugs are known to cause hyperglycemia. In addition to that, I think nutrition is a big factor in diabetes as well. So I think that perhaps we should expand these measures a little bit, especially in terms of integrated healthcare. So nutrition is one important part. And also there have to be other health measures as well. Just measuring somebody's blood glucose level is not enough. I mean, there are other comorbidities like high blood pressure, coronary artery disease, probably in older people, but still with the general health of American adults is probably the worst in the Western world, as has been reported in many peer-reviewed articles. So I think it's important that we expand these measures. At least I've been hearing about measuring diabetes or measurements for blood sugar levels for the last 5 years. I think it's time that we expand these measures a little bit. Thank you.
Yeah, no, thank you. I think that's a good point. And the Hedis measures themselves are not necessarily created or can be adapted, but I think to your point is that our attempts on addressing some of those and considering some of those other factors that you noted is important to note. So we can certainly provide also some follow-up on how we are working that in through our integrated health care efforts as well. That's a good point.
Ms. Flowers?
Yes, I was going to say just the same thing. I agree with what has been said about monitoring all the factors that are associated with diabetes, not just the A1C and so forth. But I do recognize that because of the NCQA measures, that is the HEDIS, and our HEDIS measures, that's what they measure. So we can certainly do more than that when we're looking at diabetes amongst or the possibility thereof in managing the nutritional intake, and as well as cholesterol and hypertension and all of the other areas that are very necessary to manage any health person or to increase health in anybody. So I agree with what's said. You're welcome. Thank you, Stephanie.
Yeah, thank you. Any other questions? All right, so I will move on to the final initiative I'm going to discuss tonight, which is suicide prevention efforts. So this relates to the Services and Supports Annual Plan Goal and our continued suicide prevention efforts across our network. So OCHN is continuing to implement zero suicide practices and work to improve supports for individuals at risk of suicide. So some updates from Q2. The clinical pathway for suicide care and the audit tool that goes with that pathway have both been updated, and those will both be included in the FY22 Utilization Management Manual. Those were updated with feedback from external and internal work groups. OCHN's internal zero suicide work group has updated its FY21 through 22 work plan, so that has been updated and is currently in place. And then the external network meeting that is held bi-monthly related to zero suicide, there's been during Q2 provider network collaborative sharing of resources during those meetings that occurred. So again, those meetings occur quarterly and bi-monthly, and really looking at making sure that people receiving services receive the highest quality support, treatment, and assessment, and that as a network we're implementing those zero suicide practices. So I did provide some updates for this fiscal year. For Q1 and Q2, this is the number of individuals that were enrolled on the pathway. And actually I want to correct that, because I said number of individuals and I really should have said number of enrollments on the pathway per quarter, because there could be an individual possibly who is enrolled in Q1 to the clinical pathway for suicide care, is then removed, and then could be enrolled again if risk came up at another time during that quarter even. So this is actually the number of enrollments, and it could contain duplicate individuals who may have had multiple enrollments. So I just want to clarify that bit of information. But in Q1, there was 103 enrollments to the pathway, and then in Q2, there have been 117 enrollments on the pathway. And so I think these numbers are really good, because I can say in FY20, the total enrollments there were 211. So we've already had more enrollments in the first 2 quarters of this fiscal year than we have for all of last fiscal year. And I think what that's telling us is we are moving in the right direction with our work around implementing zero suicide, and that we are seeing that as a network, we are able to identify those at risk. We're able to utilize that clinical pathway for suicide care and able to make sure that those individuals are receiving those supports and services at the time when they really need them. So I think that's really encouraging to see that number grow so much this year, and is really showing the adoption of zero suicide and its practices within our network over this year. And this is still in progress, so we will also make sure to provide an update as we go through the year on where we're at with this. And then the budget and funding. So this is an administrative funding source for the suicide prevention efforts, and this was included in the budget for fiscal year 21. Any question related to the suicide prevention efforts?
John Paul?
Thank you. Could you define what zero suicide practices are specifically?
Yeah, so we have a work plan within OCHN, and one of the things that we did during the time we had the Transforming Youth Suicide Prevention Grant is we brought in Henry Ford to do training within our network related to zero suicide. And so there's some overarching principles of goals we wanted to set as an organization. And so that included having a goal of zero suicide, right? Even if that seemed not not attainable, that was the only acceptable number. And so ways we would get there include having this clinical pathway for suicide care. So within that clinical pathway, there is information regarding like frequency of contact with an individual, if an individual is in an inpatient or acute care setting, a follow-up process, engaging with an individual who maybe there's been outreach to and we haven't received any feedback. We've provided some sample letters to send as outreach or sample discussions around that, as well as promoting training. So we do have training for staff around suicide intervention, such as assist trainings offered through our network, safe talk trainings, which are evidence-based trainings on how to intervene with an individual who may be experiencing suicidal ideations, as well as how to provide support as a community member to make a suicide safer community. So those are some of the steps, as well as having this internal work group within OCHN that meets quarterly. And we talk about how do we address, internally if there are staff needs that come up related to suicide. We have a team of individuals available. What are our processes around that? How are we responding? And then we also have a work group that's formed with our provider network around, how are they implementing, because the providers are doing a lot of work around also implementing zero suicide practices to some of those areas I talked about. So those are a few of the highlights, but we can certainly provide more information on that also, if that's something that would be helpful.
Yeah, no, that was pretty thorough. You kind of got cut off a couple times there, though, because we had some technical issues. But
sorry
the gist
about
of it is what I got was it was a very comprehensive approach with the overall reaching goal of zero suicides, like it says, and providing all of those services. And I see in there the highest quality of services and the safe talks and all those kinds of things. So yeah, I think I get it, even though you were cut off a bit. So thank you.
Yeah, thank you.
Dr. Hans?
Yes, thank you. I think that's a very worthwhile effort. I just wanted to know, this number, does that include children as well as adults? And if you could give a breakdown as to what percentage of children are included in this goal?
Yeah, so I can get back to you on the specific number because I can get that. I don't have that information with me right offhand, but it does include all populations. So it does include youth and adults. So anyone receiving services through any of our providers could be placed on a clinical pathway for suicide care if it's appropriate.
Thank you.
Mm-hmm.
Melkaya?
I don't have a question. I just wanted to add something to what Stephanie was saying. With zero suicide, especially in the core agencies, we are being taught that everybody is responsible, not just the clinicians, not just the case managers, the drivers, the front desk staff. Everyone is being conditioned to be sensitive to the possibility that a person may be at risk for suicide, which is one of the parts of this program that I love so much, that we're treating everybody as, if they present in that way, then everybody's responsible for helping to keep that individual safe.
Yeah, that's a really good point, Malkaya. I think that is a huge piece of zero suicide, and I think I noted in my last update, but this year in FY21 was the first year that OCHN had a mandatory suicide prevention training for all staff, not just clinical staff. So it really is for all, for everyone, not just for staff who have a clinical background. That's a great point. Any other questions? All right, well, thank you very much. Have a good evening, everyone.
Thank you very much, Stephanie. We appreciate the information you shared with us tonight. And next, I'm going to turn it over to Vicki Suter for the RRAC appointment.
Good evening, and thank you for the opportunity to present the recommendations of the Recipient Rights Advisory Committee. We did meet on June 3rd, and the committee talked about reappointment of Dan Burley. Dan has served his first term of 3 years. You appointed him in June of 2018. The committee unanimously would like to have him reappointed. Dan regularly attends the meetings. He participates in discussion. I've known Dan for a lot of years. He's always offering his experience, his perspective, and his ideas about advocacy. And he's just a really contributing and well-liked member of the committee. So the RRAC committee is asking that the board approve this at the board meeting next week. Any questions for me?
I'm not seeing any unless there's any anyone attending remotely for a question. No. All right. We will
Thank you.
Take it for a vote. Yep. Thank you. All right. With that, we are going to move into other business, and I'm going to turn it over to Kalana Ali for the hybrid meeting policy.
Thank you, Dr. Guadalupe. So what you have before you is a hybrid meeting policy for the board to govern its meetings as we continue throughout the year to host our meetings in person and online. As you are aware, the Open Meetings Act was amended in 2020 to allow for remote meetings in response to the COVID-19 pandemic. As this still continues to be an issue, the current law allows for the continuation of remote meetings through December 31st of 2021. As part of those amendments, it required the adoption of a procedure to actually host those meetings. This procedure or policy just simply goes through the qualifications of holding a meeting remotely or electronically, which includes the state of emergency, the medical condition, or the military duty, It also goes over the fact that, any person who intends to attend remotely also report that information to Sheila Barrett at least 72 hours in advance for planning purposes. And it also goes through the standard requirements of the Open Meetings Act, which provides that appropriate notice, the agenda must be posted at least 2 hours before the meeting in a place conspicuous. So that would be on our website, as well as for voting purposes. It also notes that if a person is not is meeting or is not in person or is meeting remotely, they have to qualify for one of those qualifying reasons, which are those 3 reasons previously stated: military, medical condition, or the state of emergency declaration. Again, this policy will continue through 12/31/2021 of this year. This is to account for the changes in the OMA. Are there any questions?
I am not seeing any, but I do want to, I think we'll talk about it further at the board meeting, but maybe just to start discussion right now. In terms of the 72-hour notice to let Sheila know, is that online in Boardable? So like where we RSVP, so you're looking, Sheila, for yes if we're in person or remote, if you're planning on remote, and you do need the 72 hours, because I think perhaps that wasn't always happening.
Yeah, it's not happening.
I didn't want to put words in your mouth.
Some people are good at it, but yeah, if people just want to mark, because when you get the invite or reminders, a simple remote attending or that would be great. They don't have to call me or email me. I can look right in there and get it. That'd be great.
Okay, so just making sure that the yes is checked if you're coming in person, or the remote if you are remote. And then the second thing, someone had asked me to ask for them in terms of the medical condition. So if they're claiming not claiming, but there is a medical condition, so can they come to some meetings and not others, or is it if you have a medical condition, you would be remote until you don't have that medical condition? I know it's kind of tricky, but I'm trying to put it in their words. I don't know. Don't know that I'm articulating it well, but hopefully you understand where I'm going.
I know exactly what you're saying, and I am not the medical police. I am not a doctor. I am not a physician of any sort. This is strictly the statute defines medical condition as an illness, injury, disability, or other health-related condition. It's very broadly defined, and it's really, I think, to account for the varying complications that could occur or expose someone to COVID-19. So to address that, if you have a medical condition one day and not another, I can't say, but, your ethics and what your own, that's going to really dictate that. But it's in the best interest to, maintain a level of honesty. But, for example, if you have a code today, but you don't have one for the next board meeting next week, you're not prohibited from attending in person. So if it falls within that guideline, I have nothing to say about it.
Okay, thank you. I see Dr. Posios has his hand up, and then John Paul.
No, I just wanted to back up Kalana rather there. We're not going to, I don't think the intention is to police medical conditions. And I don't think that that's something that would be dug into, so to speak. So just wanted to support Kalana's opinion there, although I'm not a lawyer.
Thank you. John Paul?
Yeah, I just was kind of wrestling with the medical condition question because like when I come in, I fill out the questionnaire and it asks, have you traveled outside of the country or have you left the state within 14 days? So like if I've traveled outside of the state, does that like if I have to check yes, like I traveled out of the country, or it asks if I had any contact with somebody who may have had COVID, which that happens every now and again, even though if you're vaccinated, then does that mean that I would qualify under a medical condition? So let's take that example. If I had, because this is probably the most recent thing that happened to me, somebody who had COVID, didn't get vaccinated, but never got, went through it, but they never got an end result to tell them that they were negative. They just said, oh, I don't have symptoms anymore. So does that mean now I have a medical condition, even though I'm vaccinated, that I could be potentially exposing other people? Because if you are vaccinated, you still can carry, you just have no symptoms.
I am not a doctor. So.
Yeah, it's just kind of questions that I wrestle with.
I'll leave that to Dr. Posios, but to the extent that you're asking related to whether you can attend a meeting, right now the restrictions have been lifted as such that if you have travel and you feel like you may be exposed, and so for that reason you feel like you qualify for that, I am not the person to tell you that you do not qualify for that. Again, This is not really like the medical condition police where we're saying you really don't qualify. But if you feel that you've been exposed and you want to avoid exposing others, then I think you're well within your right. And I'll let Dr. Posios weigh in on that one. But from my perspective, I don't have an issue with that.
So potentially like using your best judgment to make a determination of whether you may or may not have a medical condition. But we'll let the doctor.
Well, I can also speak to what our reopening process is. So those are actually some older questions. We are not prohibiting people from coming into the building because we are following CDC guidelines. So if you follow CDC guidelines and you have been out of the state or the country and you are fully vaccinated and you do not need to quarantine to come back into the United States, you can come into the building. If you were exposed and you are following CDC guidelines that says that you don't have to quarantine, that you don't have to quarantine. So I can't speak necessarily to the medical condition, but I can speak to what we're following for our employees coming into the building, which would extend also to board members and visitors.
Dr. Posios, did you want to add to that? You're muted.
Oh, thank you. I just wanted to add that I think that we need to be mindful of, ourselves as well as those around us. And I think that the medical condition, concept that we're discussing right now certainly pertains to not wanting to expose other people, but also to obviously wanting to protect yourself from being exposed, and if you're susceptible to severe illness, not unnecessarily exposing yourself. And so, that's why, we advocate for, at least I advocate for, universal masking while indoors, despite your vaccination status, because you don't know what you might be carrying, although it might be a low risk. There's data coming out of the United Kingdom and also from Canada that I reviewed today that suggests that the so-called Delta variant that originated in India recently has some degree of escape from vaccination. So I think that's another reason, to act with caution when we gather indoors. And that's going to be an increasingly prevalent variant, and perhaps the dominant variant by the end of the summer in the United States. So just wanted to say that and keep that in mind as we go forward.
Thank you. Mr. Cohen?
Just one clarification on the local emergency declaration. So it's my reading of that act, or the change, that while Troy does not have a local emergency declared, so our body as a board needs to meet in open session for as many as can come, that because we're a county-wide board, if our local community that we live in has declared a local emergency, that is one of the bases for being able to attend remotely. Is that correct? I just wanted to clarify that.
That is correct, and that's actually noted in footnote number 2 of the policy that states that the person who is a part of the public body resides in the location where a state of emergency has been declared.
Right.
They actually fall within the exception or qualifying reasons.
Right. I just wanted to clarify that for everybody's benefit.
Yeah.
I did read that, but I'm a lawyer and it's very legal.
Yeah.
So I just wanted to clarify. So the way to check that out is like in Royal Oak where I live, they've declared they continue the local emergency. And one of the reasons they're doing it is because they don't want to have, they are having totally Zoom meetings. They've made a decision, and that will probably be through the end of the year, because that's when the statute, that section expires, unless it's continued. So you could probably check whatever community you live in, go to their website, and they typically most communities have a COVID section. Although just my analysis is, I think medical condition doesn't just COVID. It could be any medical condition. If you are feeling lousy that day and don't want to come,
it's very broadly defined, which is why I said, I'm
Right.
not the medical condition police, because if you don't feel well a day, and as Dr. Posio stated, you don't want to expose yourself or anyone else
Right.
unnecessarily. It just, doesn't make sense.
Exactly. So you could go to your local community that you live in to their website. You'll be able to figure it out. And if not, just call the clerk's office. They'll tell you. Okay. Thank you.
All right. Any other questions or comments from those in person or attending remotely? Not seeing any. Thank you, Kawana. So that'll be something that will be taken up for a vote at the board meeting?
Correct.
Thank you. All right. We are moving to our second and final opportunity for public comment.
We did not have any public comment this evening.
Thank you. And now board member comments. Sheila, if you could go through, please.
Mr. Torres?
I think I just wanted to make a statement that I appreciate the OCHN and the collaboration with the police department. And I know they came to us in Birmingham, Bloomfield, and Auburn Hills. I think that's a great initiative. I've seen that in practice in other communities, and it's effective. So I think we're definitely in the criminal justice field and in the courts more encompassing of this the mental health aspect of things, which I think has come a long way in almost 20 years in my career, and it wasn't like that when I first started in the courts. So I am glad to see that, and I appreciate the information tonight. Thank you.
Mr. Cowan?
I agree with the comments Jean Paul made. I've had a chance to talk to a couple police organizations and senior people that I was trying to recruit to, because I think we have training that is for police departments that's separate from that and they didn't know about it. And so I'm going to pass that information along. But I will tell you, and coming from a police family, there's no question police departments will welcome any assistance with mental health engagements that they have, because they just don't have as much training. It's not the focal point, but it's something that, because of state policy, unfortunately, that they have to deal with on the front line. So I think they'll welcome any type of assistance and training. So I think if we can get that word out, and I would note that about a third of the communities are covered by the Oakland County Sheriff's Department, that they contract for police services. Now, most of those are in the northern communities. That's just historically how it developed. Most of the southern communities had their own police departments. And I think that should be approaching the Sheriff's Department because they cover, I believe it's 15 or 16 communities in Oakland County. So, but thank you.
Dr. Hahn?
Learned a lot today, and I would like to welcome our new clinical coordinator. Welcome aboard, and I think that will certainly improve the services that we provide to people that we serve. And welcome. Thank you.
Mr. Lindemeyer?
I would just like to welcome our Chief Clinical Officer as well. It's great to have you here. I've enjoyed getting to know everybody and working with everybody. I'm fairly, new, just here since a year ago, April. And it's been a great group to work with. I think you'll enjoy it. Thank you.
Ms. Root?
Thank you, everyone, for the updates provided tonight, and welcome, Kimberly Flowers. We're so happy to have you.
Dr. Taub?
I don't know about the rest of you, but coming out of this pandemic and being able to meet with people and see their faces really gets to your emotional core. It's like having a new puppy or something. But I really feel, well, what if you had a puppy and it had a mask on? How could you relate to it? So I'm really happy. And welcome to.
Ms. Newman?
Thank you so much to the staff for the information they provided, and a special thanks to the IT department for the new tablets. Even though I'm the holdout, I'm not an Apple product person, and they know that, but they walked me through very carefully, and I'm trying to get this. But with that being said, I also wanted to mention that on some of the screens, you can't read all of the information. And I don't know how we're going to do the slides and stuff because they weren't part of the presentation tonight. At least they weren't on my tablet. So if I was at home looking, I wouldn't have seen. Well, I would have been on Teams. But if we're here, okay, I'm confused. But anyway, I still would like to get the slides. Even though I don't need them printed, but I still would like to get the packet like we used to get it so that we can read it, because going through it in the meeting is kind of quick and it's a lot to take in. So if we could still, it's a request on my part. I don't know if I'm the only one, but I would like to still get the slides.
Yep. I can walk you through. You can print the board packet right on Boardable.
Thank you.
Yep. Ms. Tammy Dyer?
Sorry, I've been having some issues with my computer all day today. I apologize for that. Sorry, I came in a little late today. I did put it in the chat, but I did just want to indicate that I am remote from Farmington Hills. And for when I've been in on this meeting, thank you everybody for all of your presentations. As always, a lot of really good information. So thank you to everybody and have a good night.
Ms. Bernard?
I want to thank everyone for this very informative meeting and also welcome Kimberly Flowers. She's got a great group of people that she'll be working with, and we're really, really happy she's here to share her expertise. So that's about it. Everyone have a wonderful evening.
Mr. Furman?
Yes, I just wanted to again echo the really in-depth departmental presentations tonight. They really generated a lot of interesting and fruitful discussions. And welcome, Kimberly Flowers. Thanks. Have a good night.
Mr. Landsman? I'm not sure if he's still on, but if you are, you're muted. Yeah. Dr. Guadalupe?
All right. Yeah, thank you to everyone for your presentations tonight. Thank you as well to IT for helping all of us navigate through these glitches that some of us have been having, so we appreciate that. Welcome, Kimberly, and I just want to give a shout out to Dana too, because I think in the last couple months things have really evolved here with a lot of new we've got a new chief legal officer, a new clinical officer, our new chief medical officer. I don't know if I'm giving all the right titles the correct name, but I really think you're on a good path and good momentum moving forward, and I think it's great to see all these positive changes. So thank you. And with that, I will need a motion to adjourn our meeting.
Motion to adjourn.
Do we have a second? All right. Thank you much. Everyone have a great night.